it is my pleasure now to introduce again Professor Falk Bechara. I would like to thank Novartis for sponsoring this session. Dr. Bechara is the head of the dermatologic surgery and the senior consultant at the Department of Dermatology and Allergology and Venereology in Ruhr University in Bochum, Germany. He actually founded the Center of Hidradenitis Suppurativa Acne Inversa in Bochum, and Dr. Bechara is well known to all of you. It is my pleasure to introduce him. He will shed the light on hidradenitis suppurativa. Please, Dr. Bechara.
Yes, thank you so much again, and welcome you to this symposium where, with you, I would like to focus a little bit on the, focus a little bit here, my disclosures, on the role of IL-17 more and some ideas about introducing IL-17 into the treatment. I mean, we just had a talk on HS before, so we had the guidelines. I'm not going to double anything or try, so maybe we have the time also for other questions. I guess you're all aware of the fact that the last 5 to 10 years, it has become a very popular disease. Everybody's talking about it. When we started 20, 25 years ago, nobody wanted to hear about HS. But now it's a very fancy disease and a lot of science, and we understand more and more. However, we still have a lot of gaps in understanding the disease. I think what is absolutely clear is that we have a immune dysregulation with a vicious circle of pro-inflammatory cytokines ongoing. We do see some risk factors, obesity, smoking. There seems to be a familiar component that we do not understand perfectly, but about 30–40% somehow describe positive family history. And we also still discuss the role of bacteria, so don't get me wrong, it's definitely not an infectious disease, not at all, but there is definitely a pro-inflammatory boosting of bacteria, especially in the follicular opening, and once this bursts, so the amount of bacteria play a pro-inflammatory role, and that's probably also the reason why sometimes antibiotics are working even if they are given short-term and not long-term in a more anti-inflammatory approach of an antibiotic. So I told you, and we had a nice question from the last chair, why do we use TNF? Why do we use IL-17? And the simple question is, well, it's like always when you start, you look at the blood, you look at the tissue, what is elevated, then you have your first case series, you have your proof of concept studies. And it's not like, just imagine, the first drug was approved in 15. The second drug in 23, so that's 8 years. Does not mean nothing happened in between. It happened a lot, but all the molecules failed, if we're honest. We tried so much, so many studies were ongoing. They all failed. One example is the whole IL-23 program. The whole 23 program did not work in HS, so it was a little bit try and error. And nowadays we have identified TNF, we have identified IL-17, but there is a lot ongoing, about 45 parallel ongoing trials in HS at the moment. And the most promising pathway are also the JAKs, which are in phase 3, the IL-1 alpha-beta combination in phase 3. We are going to see also different targets like B-cell targets, very interesting. And we think that at the moment it is discussed that probably there is a T-cell dominant HS type, a B-cell dominant HS type, and probably this will divide within the next year the treatment approach in those patients. So what we know much better, and you all know that, are the different lesions that are created. And by the way, it does not need more than this to diagnose the disease. That's probably something we should do better, not we as derms, because I think we are all well aware of the disease, we're well trained, but we should do better in bringing it to the emergency doctors, to the GPs. It's so simple, yeah? What do you see? Where do you see it? How often do you see it? That's it. Abscess, nodules, fistulas in the inverse areas more than 2 times in 6 months, that's it. 99% chance of HS. So it can't be simpler. You don't need biopsy. You don't need nothing. So we have seen that picture before. And here, I'm showing it always because I'm not a big fan of the Dutch. As a German, we're not. But I like the slide and their paper because they clearly put on a slide for the first time the heterogeneity of the disease. And it shows one thing else that I mentioned shortly before, and that is the so-called window of opportunity in HS. And the window of opportunity means probably we're dealing with a disease that nowadays we are treating in most cases outside the blue box, when fistulas and scars are already there. In an ideal world, that would be ideal. We don't have that in Germany, not in US, not in the Gulf region, but in an ideal future world, probably we would start to treat them like nowadays in Crohn's, when there's just inflammation before the proctologic surgeon has to treat the fistula in Crohn's. That would be ideal. And that's the concept of the window, but I know it's not taking place at the moment in reality. And if we discuss about that concept, I can just tell you there are some indirect data that you see on the left side. There are studies, to summarize, that tell you the later you start with a biologic, the less response you have. There's a cutoff value of 10 years in some papers. Another paper has shown that even if there is response, the number of flares still is much higher in those who had a late diagnosis. So it all shows that we should do better than we do. And again, that is the reason, you've seen the slides before, that is the reason why a guideline in HS includes surgery. It's the only reason. There is no surgery in psoriasis, obviously not in atopic dermatitis. That's the only reason, because they progress. And I've shown you also the differentiation. Again, use a score. I don't want to repeat it, but I tell you the following. In your daily practice, I don't tell you use this or that score, but use something at least, something for your payers, something for insurance, and something for your own evaluation, what your medication is doing with the patient. We in Bochum, we are using IHS4, yes, but we're also using SAHS and Hurley, but that is something, well, probably the US will use more like a HASI or something, but it's something you should use to evaluate your patient. Until today, all the scores, unfortunately, are counting, okay? So then you have seen the surgery I told you, again, the evolution of it. I will not repeat that, but I give you a different advice here. I give you the advice as follows. You cannot train a derm to become a derm surgeon if it is not implemented in your board certification or in your country. There is no sense in trying to perform like you do probably in Germany, where you train 50% in surgery during your board certification as a derm. Derms in Germany are half surgeons. But you can try to learn something and establish something in your own practice that is simple. And I think a de-roofing and a small excision is easier than a mole excision or a BCC removal. And most derms are at least trained in that. And if you think about this, then I strongly advise you to form something like a training program or something to do at least the small procedures, because that means the world to the patient. It's not the complex stuff I have shown you before. It's the small things. It's the guy who is on a biologic, but he's flaring up with 2 fistulas and then regarded as a non-responder. That's not good, because then you would switch the medication. Then you would add something. Instead of just removing those little 2 small fistulas in your office in 5 minutes, and then it's responding again to the biologic. And that's just my advice here. And now I wanted to go with you a little bit through the IL-17 pathway. I told you what we have. I told you we have now 3 labeled drugs. And let's see why there was a need to go to IL-17. Well, generally it was just the fact that TNF is responding, but just in 50%. That's the reality. 50% response, and the response, when you read the paper's response, what does it mean? High score means it's just 50% response. So 50% respond 50%. So it's not PASI 90, no PASI 100 or nothing. And over time, in TNF, we often saw that there's a decline in response. And that, for sure, in such a severe disease, led to all the programs to get more efficacy. And here is now what we achieve on the first saw with seco. So on the left side, I told you there's no huge response. It's also 40 to 50% response. So we don't have the breakthrough like saying we have the miracle drug. That's not the case. But we have an alternative now for non-responders and even naive patients. And we have a drug that probably, if you look on the left side, seems to keep the stability and even get better over time. So that we have an augmentation of response up to 60% over time. And these data have been collected in the so-called SUNNY program. So that was before the label in 23, the largest IL-17 program that we had. And you can nicely see here on the graphic in this pooled analysis how the seco every 2 or every 4 week responded until week 16, then over time are stabilized and getting better. But you can also see, and that's the big question always, placebo rate is quite high in HS. It's always somewhere 25, 35%, so that's something to mention. And the next good message from seco is, we had sub-analysis with the question, how are patients behaving that had no biologic before, so bio-naive, and how are they behaving if they had TNF before, so TNF non-responder, actually what we were seeing for years. And there you can see on the left side week 16, on the right side 52, then you have the different dosing schemes. But you can see at week 52, although in the beginning there seems to be a very small difference, over time the response is similar. So you can tell your patient who is coming and failed to adalimumab or biosimilar, whatever, you can tell them, okay, we will have the same response with seco as in a patient who did not have any biologic before. And the second sub-analysis I would like to show you is the question that arises in daily routine very often. You have patients who underwent surgery before, 1, 2, 3 small radical surgeries, and we regard them always as more severe. Obviously, they had surgery. So, and very often the question comes, well, does the medication help me? Will it help me because I had already surgery? And we have now the sub-analysis of those who had previous surgeries versus those who had no surgery before. And it's similar to biologics. It is surgery naive and surgery experienced patients respond the same. So you can also give it to those who responded to surgery. And there are some other data like the flare rate that you have. And if you look at the flare rate at week 52, so over time, there are about 70-75% of patients who stay flare-free. Well, a third still gets flares, but 2/3 are flare-free for a period of 1 year. For the patient, that is quite important as the quality of life, because it's a patient-centric approach that we have, and it's not only about counting, but it's about how the patient feels. And if his quality of life gets better over time, that is an important point. And at least as important is the question, how is the pain doing over time? And if we have a stabilization of pain on a longer period of time, that can be a success story, although maybe your AN count, abscess nodule count, is not perfectly decreased, but as long as the patient is pain-free and happy, that's extremely helpful. And we also have a good effect on the development of new draining tunnels. And we can see that over a year, 80% of the patient at least have no increase in draining tunnels. So don't get me wrong, that's not a direct sign for disease progression prevention, no, but at least the draining tunnels, which have the most or the strongest effect on patients' daily life, are not augmenting over time, and we have the same safety profile than we have with psoriasis. Because this was a big question in the IL-17 in all programs before. What is Candida doing? What is IBD doing? What are these things doing in HS? Is it really different to the moisture regions? Do we see more Candida? And I can see we see Candida, but it's something similar in the number that we know from psoriasis, and we can treat it similarly. So it is not something that affects us more than the year-long experience in psoriasis. So, and now I brought some just some cases for you to imagine. We have seen some cases already before, but here are some other cases. So here's a guy. You see on probably you see the drainage, right? That's what he's coming. He's coming, and that's typical. They go in, the nurse needs 35 minutes for wound dressing. It's so painful, it's oozing. You have to wait 25 minutes to see the next patient because there's such an odor of the disease. Well, you all know that from every day. And for the patient here, in the first place, it's not healing. What he wants to get is just to become pain-free. That's what he wants. Pain-free and probably not having his disease being visible for everybody else and oozing out into his clothes, etc. So, and that's what you can achieve, but not, please, again, not healing. So that would be a case of monotherapy. In the talk before, I emphasized on the fact that sometimes patients are so severely affected that it is not working with monotherapy, that we should combine. And I'm not always talking about surgery and medical, but also about combination of medical. And now I'm going to show you a case which probably would agree is severe. And in my opinion, it's not only severe, but it is so severe that you cannot even score it. I would not be able to score it. I can tell you it's Hurley 3, that's easy. But if you start now, where is a nodule? Where's an abscess? Where is a fistula? It's impossible. I can tell you at least two interesting things. Look at the groin, so meaning here, the groin and the scrotal area, and look at the inner thighs and the legs. You will see a difference. You will see that here in the groin you have, and that's important, you have chronic fistulas for years and years and years. And when you have fistulas for a longer period of time, you always have accordion-like, cord-like scars above. That's just an indirect sign for the damage in deep tissue. But you also have new, fresh cavities everywhere. You could take forceps here and just pull, and you would probably have the skin in your hand. So, for sure, he's coming in a wheelchair. He is in his 20s. His mother is bringing him in the wheelchair. The whole family is destroyed, stopped college, no girlfriend, for sure. So now is the question, surgery, well, probably, but not in that stadium of disease because he's just too inflamed to infect it. And I would think that this guy would not respond sufficiently only to a biologic. And that is exactly the clinical situation that I meant, where, say, we go in with all that we have, in this case here, IV ertapenem, 6 weeks, followed by the French triple antibiotic scheme. So really everything that you have as anti-inflammatory potency with antibiotics, plus secukinumab, in this case secukinumab, or plus a biologic. And now you see something super interesting. The guy there on the left side is the same patient, no surgery, nothing else. And you see two things. First of all, he is now nearly pain-free. He's walking the first time, he restarts college, and he is getting out of his depression. The whole family is getting out of its depression. And you see something, all fresh cavities, ulcerations, and new tunnels are completely healed, not healed. And so that shows clearly the window of opportunity. We can act if we are very early, if nothing is epithelialized. But you can also see, look at the scrotum and the groins. There's no effect. It's probably not draining. But you will never be able to resolve the strong fistulizing parts of the groin. Okay? So that is surgery then. But he's happy. He's really happy. That's a good result. And so we will, again, like in the last talk, gain trust. This is a marathon HS. We will do the surgery. And a case like this, after 1.5 years, after 2 years, is healed. But it takes time. And the last point I would like to discuss with you very shortly, it's not a very nice image, but the question is combination of surgery and medical. You know that there are clear data for adalimumab. It's absolutely safe. I just wanted to tell you we are doing it, but we don't have safety data yet for IL-17, neither for seco or bimekizumab. We don't have safety data. I personally think, why shouldn't it be safe if ADA is safe, but we don't have the data. We're trying to build up the studies now and go for surgical studies with IL-17. But you can combine it, honestly, and we do that every week. And by this, I would like to come to an end and be very happy to get any question.
Thank you, Professor Bechara, for the very informative data and cases. We'll have the floor for a few questions, but I want to ask myself, actually, very challenging question clinically that we face in our practice. Always the patient will ask, for how long shall I go on biologics? And my last point will be about the role of ultrasound in the evaluation of the staging and or the severity of HS and its reflection on the management.
Yes, thank you. So the first question is about Q2, Q4. So I would answer it that way. If you look at the data, at the counting data of the SUNny program, they behave similar. There's not a huge difference. If you go to quality of life, pain, then there is in some patient-related outcomes a tendency that Q2 is doing better, but in the label you have the flexibility for both. So in the label it's stated that you should start with Q4, see how the patient is doing, and then go to Q2. We have about 50% of our patients on Q2, 50 on Q4, and I personally think from my clinical experience Q2 is more effective. I personally think I see a difference and it's more potent to go to Q2. If I go to Q2, fortunately the flexibility is not linked to a scoring system or anything. It's your decision as a physician, and you don't have any time points how long you can, could or should stay. It is a clinical response. If the patient is stabilized and doing very well, then we discuss with the patient, you want to go back to Q4, you want to try, and if not, then re-augment. But the most important thing, the most important thing is the question, why do you want to augment? Is it a general systemic boost or flare? Or is it what I mentioned, the typical 1 or 2 fistulas that are not responding? And then probably instead of going to Q2, take out the 2 fistula, and in some cases, then you're super happy with Q4 instead of directly boosting. So that's again the puzzling. Yeah.
And how about ultrasound? Do you use it?
Yeah. So we have an ultrasound 18 megahertz probe. I don't use it. My residents use it. Some senior colleagues use it. I think if you're doing experienced and tough surgery, you don't need it. You know where it goes, how it feels, just in palpation. I have the impression I'm as good as the machine, but I completely agree. If you are not doing a lot of surgery, or if you want to show the patient the extent of the disease and he's not believing you because he tells you, doctor, there's just 1, 2 nodules, what are you talking about? Because it's just the opening of the fistula and the fistula is 15 centimeters, then ultrasound can be very helpful to show the patient the extent of the disease and to convince him to say, you need surgery, look at the picture and the network of tunnels. Yeah.
So the floor is open for questions. Yes, please.
Hello. Thank you so much for the very lucid presentation, sir. I just had a query about how important is to consider Kebner's phenomenon in the timing for surgery, and when can they safely go for laser hair reduction, considering...
sorry, the first one?
Kebner's phenomenon.
Yeah?
Kebner. Huh? Kebner phenomena like psoriasis.
Kebner phenomenon from surgery. Yes. Okay. So, well, that is a good question. So let me describe 3 things that can happen. First thing, that's just clinical experience, but there are no data. First thing is you cut out, for example, the axilla, you bring out a lot of inflamed, destructive tissue, suddenly the other areas get better because you reduce the amount of inflammation in the patient and other areas get better. On the other side, you will also have patients where it's the opposite. Yeah? They never had genital HS. You get out the axilla and you have the impression, well, not scientifically spoken, then the inflammation wants to get out somehow and then they develop something here. The phenomenon of Kebner in surrounding surgical areas, in my opinion and the experience, is due to the wound dressing and the wound healing very often. You will see that if you use too long, if you have sticky gluing dressings, whatever, and you have a moisture healing and not a perfect wound management, very often you develop folliculitis, initial nodules surrounding the surgical area. But in my experience, it's mostly done to an inappropriate wound management, which sometimes takes weeks and months after surgery. And if that is not done perfectly, you will get that things that look like Koebner in the surrounding area.
Thank you so much, Professor Bechara.